Imagine buying a widely popular, like culturally celebrated natural supplement,
Right, something everyone just assumes is totally harmless.
Exactly. You purchase it assuming it's completely safe.
Hmm.
Maybe you're taking it to relax, to help you sleep, or just because it's heavily marketed as this organic alternative to pharmaceuticals.
Yeah, the whole natural is safe narrative.
Right. And you expect a warning label if something could go wrong, right? Like you expect informed consent.
Absolutely. You want to know the risks.
But what if that exact same harmless plant carried a hidden, massive risk of triggering a sudden, catastrophic heart attack in entirely healthy people?
It's a terrifying thought, honestly.
Yeah, and what if the medical establishment, when they're trying to treat you for it, just blindly threw a standard, cholesterol-lowering protocol at you because they basically don't actually know what to do with a drug-induced heart spasm?
Yeah, I mean, it's a terrifying scenario. You're walking into an emergency room with a very specific chemical-induced vascular crisis, and the system is effectively treating you for a lifestyle disease you just don't have.
Which makes no sense.
None at all. The gap between public perception of this substance and the raw physiological reality happening in emergency rooms right now is, well, it's staggering.
And that gap is exactly what we are tearing into today. We're looking at informed consent, or really the complete lack of it, surrounding the cardiovascular dangers of cannabis.
This is such a crucial topic for us to unpack.
It really is. And the driving force behind this entire deep dive is a man named Steve Collins. Steve is a 53-year-old guy who, just days ago, on June 24th, 2026, suffered a severe cardiovascular event.
Wow, so this is incredibly recent.
Extremely recent. He is actively navigating his recovery as we speak, but he felt compelled to get this information out there because, frankly, he wants to save lives.
And you have to respect that. To go through something so traumatic and immediately think of warning others.
Right. His core message to anyone listening is that the cannabis industry is obscuring this data to protect a massive revenue stream, and that standard medical lipid dogma is failing patients who are having these specific, life-changing cardiac events.
And Steve's perspective is vital here because he isn't just, complaining about his hospital stay. He didn't just leave a bad review.
No, he did his homework.
He really did. He dove into the medical literature to figure out exactly why his heart failed, and he brought the receipts. He compiled a stack of clinical data that forces us to look at the undeniable biochemical reality of what THC actually does to the human vascular system.
So I want to lay out exactly what we're looking at in this source stack because it is heavy.
It's a lot of data.
It is. We have Steve's official NHS cardiology discharge summary from the Norfolk and Norwich University hospitals. This details his heart attack and the exact medications they sent him home with.
Which, as we'll see, is very revealing.
Very. We also have a meticulously researched clinical advocacy brief that Steve himself wrote to challenge his doctors at his upcoming July 9th rehabilitation appointment.
Which is just wild to me.
Right.
Writing a brief for your own doctors.
I know, it's incredible self-advocacy. Then, to prove this isn't just a one-off anomaly, we're bringing in a comprehensive clinical case series from SUNY Downstate. This tracks marijuana-associated heart attacks in young people.
The demographic shift there is going to shock a lot of people.
Oh, absolutely. We're also looking at peer-reviewed reports on cannabis-induced myocarditis, and finally, the strict, uncompromising guidelines that anesthesiologists use when dealing with cannabis users before surgery.
Right. It's a literal mountain of peer-reviewed data. And for you listening right now, it's really important to understand our lens here.
Right, our perspective.
Yeah, we are purely looking at pathophysiology. We aren't taking sides on anything else. The cardiovascular system does not care about legalization campaigns or political debates or industry marketing.
It just reacts to what you put in it.
Exactly. It responds strictly to chemical inputs. And the inputs we are analyzing today are demonstrably triggering profound vascular crises.
Okay, so let's start right at the epicenter of this. June 24th, 2026. Let's look at what actually happened inside Steve's chest. Because understanding his specific emergency is the key to understanding why standard medical protocols are, frankly, dropping the ball here.
Let's do it. If we pull up his discharge summary, Steve was admitted as an emergency for a STEMI.
A STEMI.
Yeah, and for anyone unfamiliar with that term, STEMI stands for ST elevation myocardial infarction.
Okay, let's break that down a bit. When I hear myocardial infarction, I know that's the clinical fancy term for a heart attack.
Right, exactly.
But what does the ST elevation part actually mean for the patient, like literally lying on the gurney?
Well, when you look at an electrocardiogram in ECG, you see that classic line, right?
Yeah.
The one with the spikes and dips tracking the heart's electrical rhythm.
The one you always see beeping in movies.
It's exactly that one. The S&T waves represent a very specific phase of the heart's electrical cycle. It's the moment when the lower chambers, the ventricles, are resetting themselves after a pump.
Okay, so they're gearing up for the next beat.
Right. Now, when a major coronary artery is completely entirely blocked off, the heart muscle cells in that area are instantly starved of oxygen, and they start dying.
Which is terrifying.
It is. And that massive injury alters the electrical current in the heart. It causes that specific ST segment on the monitor to literally elevate above the baseline.
So an elevated ST segment is basically a blaring red siren on the monitor telling the doctor, hey, a major artery is totally occluded right now, and heart tissue is actively dying.
Yes, it is the classic widowmaker presentation.
Ah.
It requires immediate life-saving intervention. They have to open that artery as fast as physically possible to save the muscle.
So they rush Steve, a 53-year-old guy, straight into the cath lab, and they perform an angiogram.
Which is the standard protocol.
Right. And an angiogram is where they thread a catheter up to the heart, inject a special dye that shows up on an X-ray, and physically map out the plumbing of the coronary arteries, right? Just to find the blockage.
That's exactly it. And in a 53-year-old presenting with a massive STEMI, a cardiologist goes in expecting a very specific environment.
They think they know what they're going to find.
Absolutely. They are anticipating severe, progressive, atherosclerotic disease. They expect to look at the screen and see arteries heavily narrowed by decades of thick, hardened cholesterol plaques.
Just gunk at pipes.
Yeah, the assumption is always that one of these vulnerable plaques has ruptured, which causes a blood clot to form and completely block the artery.
But I'm looking at Steve's angiogram results right here in the source text, and that is absolutely not what they found.
Not even close.
The report states his left main stem was completely normal. His left anterior descending artery, the LAD, only had mild plaque disease. His circumflex artery also only showed mild plaque. And his right coronary artery, the RCA, had less than 50% stenosis. Wait, let's slow down on that last part. What does less than 50% stenosis actually mean in a clinical setting?
Well, stenosis simply means narrowing. So the RCA was less than half narrowed by plaque. In the cardiology world, a narrowing of less than 50% is considered non-obstructive.
Oh, so it's not even a real issue.
Right. It's not severe enough to significantly restrict blood flow under normal conditions. And it certainly shouldn't spontaneously cause a massive ST elevation heart attack. His plumbing, all things considered for a 53-year-old guy, was remarkably clear.
Okay, so I am confused then. If his arteries weren't blocked by a ruptured cholesterol plaque, how is his heart dying? I mean, how does he have a STEMI with clear plumbing?
Because the plumbing didn't get clogged. It clamped shut.
Clamped shut.
Yeah. The ultimate diagnosis on Steve's discharge sheet is STEMI secondary to a coronary spasm. This is also clinically known as Prinzmetal's angina or variant angina.
A spasm, like a muscle cramp in your calf, but happening in a heart artery.
That is actually a very apt way to think about it. You see, the coronary arteries aren't just static, rigid plastic pipes. They are lined with a thick layer of vascular smooth muscle.
Okay.
And this muscle's job is to gently constrict and relax, to regulate your blood pressure and flow. But in a coronary vasospasm, that smooth muscle suddenly, violently, and inappropriately hypercontracts.
So it's squeezing itself.
Yes. It squeezes the artery so tightly that it completely chokes off its own internal blood supply.
So the artery is physically fine on the inside, like no big blockage of plaque, but the walls themselves are just crushing inward, starving the heart.
Exactly. It mimics the exact electrical signs and the exact tissue damage of a ruptured plaque, but the underlying mechanism is entirely different. And we know just how violent this spasm was, how severe the oxygen starvation was, by looking at Steve's blood work.
Oh, right, the troponin.
Specifically, yes, his troponin I levels.
Okay, I see troponin I on the sheet here. What is it and why does it matter so much?
Troponin is a specific type of protein complex found inside the muscle cells of your heart. It acts like a little latch that helps the muscle fibers slide together and contract.
Okay, so it helps the heartbeat.
Right. And under normal, healthy conditions, troponin stays safely locked inside the heart muscle cells. It does not belong in your bloodstream.
But if a cell dies?
If the heart muscle is starved of oxygen during a spasm, the cell walls literally break down and burst. They spill their contents, including that troponin, directly into the bloodstream.
Oh.
So when doctors draw your blood and find troponin, it is absolute undeniable proof that heart tissue has died. The higher the number, the larger the graveyard of heart cells.
Jeez. Well, let's look at the numbers, because this is where the severity becomes really undeniable. The standard normal range for a healthy male's troponin I level is less than 34.2 nanograms per liter.
Keep that number in mind, 34.2.
Steve's troponin I was sitting at 529.
Yeah, that is an astronomical elevation.
Mhm.
It indicates profound acute myocardial injury. His heart took a massive, heavy blow from this spasm.
Okay, so Steve survives this terrifying ordeal. His artery finally relaxes, the crisis passes, and he's preparing to be discharged from the hospital.
Which brings us to the discharge paperwork.
Right. And this is where we hit what Steve calls the lipid dogma protocol and where his massive pushback begins. I'm looking at his discharge medication list right now. Let's walk through what the NHS actually sent him home with.
Sure.
So he gets aspirin and ticagrelor.
Okay, those are antiplatelet medications. They prevent blood platelets from clumping together and forming clots. Given that his artery just suffered a major trauma from the spasm, making the blood a bit slippery to prevent a secondary clot is standard, and it's prudent.
Yeah, makes total sense. Then he gets ramipril, which is for blood pressure management. And he gets diltiazem SR.
Now, diltiazem is a calcium channel blocker. This is highly specific and totally appropriate for his condition.
Because calcium causes contractions.
Exactly. Calcium is the signal that tells smooth muscle to contract. By blocking the calcium channels in the coronary arteries, diltiazem forces the blood vessels to relax and stay dilated. It directly prevents another spasm.
Okay, so far, this all seems completely logical, right? Anti-clotting, blood pressure control, and a spasm preventer. But then, right at the bottom of the list, he is prescribed an 80-milligram dose of atorvastatin.
And just for context, 80 milligrams is not a starter dose. That is the absolute maximum high-intensity dose of a statin available.
Wait, hold on. I know what a statin is. Like, millions of people take them. Statins are drugs designed to drastically lower LDL cholesterol, the bad cholesterol, over years and years to prevent the slow buildup of atherosclerotic plaque. Right?
Yeah, is their primary mechanism, yes. They inhibit an enzyme in the liver that produces cholesterol, thereby lowering the circulating lipids in the blood. They are the absolute gold standard for treating progressive, lifestyle-driven coronary artery disease.
But we just established that Steve doesn't have progressive, lifestyle-driven coronary artery disease.
Exactly.
His angiogram showed mild, non-obstructive plaque. His arteries were relatively clean. And right here on his NHS GP information sheet, it dictates this rigid mandate. It literally says, high-intensity statin therapy continued for secondary prevention of myocardial infarction, aiming for an LDL cholesterol of less than 2.0.
It's an algorithm. Across the entire Western medical world, if a patient presents with any acute coronary syndrome, whether it's a STEMI, an NSTEMI, or unstable angina, the automatic programmed response is to discharge them on a high-intensity statin.
Without even looking at the root cause.
It is written into the foundational guidelines of nearly every major cardiology society.
I have to stop you there because this is the exact point where Steve is just throwing his hands up in the air, and I completely agree with him. Let me try an analogy here to see if I'm understanding this mismatch correctly.
Go for it.
Imagine you're in your house and suddenly a massive electrical surge blows out the wiring, sparking this huge fire in the walls. The fire department shows up, smashes through the drywall, and puts out the flames. But the next day, the city sends a contractor to prevent future fires. And the contractor's entire aggressive strategy is to bring in heavy chemicals to violently scrub out your plumbing pipes to make sure your sinks drain better. You'd look at him like he was insane. You'd say, the plumbing isn't the problem. The pipes are mostly clear. We had a sudden electrical surge.
That analogy perfectly encapsulates the frustration of a patient caught in an algorithmic medical loop. The hospital system is treating Steve's plumbing when he actually suffered an electrical and chemical misfire.
Right. If Steve's heart attack was caused by a spasm, a sudden muscular clamping triggered by an acute event, why is the medical system hammering his liver with an 80-milligram maximum dose statin designed to treat long-term progressive plaque buildup? I mean, are doctors just ignoring the angiogram?
They aren't ignoring it out of malice, I promise you. They are operating within a system that demands standardization. Hospitals, especially massive public trusts like the NHS, are processing thousands of patients a day.
So they just use a blanket approach.
They rely on lipid-centric protocols because they have to treat the statistical majority. And the overwhelming vast majority of heart attacks are caused by plaque rupture. The system is defensive. It's designed to cast the widest possible statistical net.
An assembly line approach to medicine.
Precisely. The systemic issue is that this blanket approach fails to accommodate specific etiologies.
Meaning the actual causes.
Right, the root causes of a disease.
Hmm.
When a patient comes in with a substance-induced vasospasm, the system simply isn't built or funded to pivot to personalized root cause analysis right at the point of discharge. It's much easier to plug you into the existing algorithm, hand you the high-dose statin, and push you out to the rehabilitation clinic.
And this is exactly why Steve drafted his clinical consultation advocacy brief. Because the hospital treated him as a standard progressive plaque rupture patient, Steve realized he was going to have to fight for his own informed care.
He took matters into his own hands.
He really did. He's basically telling the system, no, I am not a statistical average. I am taking my health into my own hands.
It is a remarkable, almost unprecedented document for a patient to prepare. It demonstrates a refusal to just be a passive recipient of generic, potentially inappropriate care.
So he prepared this brief specifically for his July 9th cardiac rehabilitation appointment with his cardiology team. He opens the document by stating, completely unequivocally, that he has achieved 100% total cessation of all cannabis and tobacco.
A critical first step.
Smoked, vaped, oral edibles, oils, everything. He stopped cold turkey on June 24th, the very day of his heart attack.
And from a clinical perspective, regardless of whatever medication disputes follow, that immediate total cessation is the single most vital intervention he could possibly make for his own survival. He removed the primary suspected toxin.
But then he immediately goes on the offensive. He explicitly rejects the hospital's guest etiology. He refuses to accept that his heart attack was the result of progressive, lifestyle-driven plaque.
He's challenging the algorithm.
He tells his doctors point blank, I do not need a lipid-centric protocol for obstructive disease I do not have. Instead, he presents them with a root cause resolution strategy targeting two very specific triggers.
Right.
Chronic, high-volume cannabis consumption and severe sleep deprivation.
This is where Steve demonstrates a really sophisticated understanding of cardiovascular pathophysiology. He breaks down his own hypothesis into 4 clinical mechanisms. Let's look at the first one he presents, autonomic overdrive.
Okay, so he writes in the brief that chronic, heavy THC intake induces acute, dose-dependent sympathetic nervous system activation, driving catecholamine surges and tachycardia.
Yes.
I need an ELI 5 on this. Explain it like I'm 5. What are catecholamines and what is the sympathetic nervous system actually doing to the heart?
Okay, so the human autonomic nervous system has 2 main branches. There is the parasympathetic nervous system, which is your rest and digest mode, and there is the sympathetic nervous system, which is your fight or flight mode.
Right, the adrenaline mode.
Exactly. When you consume high doses of THC, it acts as a massive trigger for that sympathetic nervous system. It forces the adrenal glands to dump catecholamines, which are stress hormones like adrenaline and noradrenaline, directly into your bloodstream.
So the body basically thinks it's being chased by a tiger, even if you are just sitting on your couch playing video games.
Exactly. And the heart responds to that adrenaline. Your heart rate violently spikes, which is what tachycardia means. Your blood pressure shoots up. Suddenly, the heart muscle is working incredibly hard and demanding a massive amount of oxygen.
But you're not actually exercising.
Right. It is doing this in a state of chemical panic, not natural exercise. This autonomic overdrive leaves the electrical and muscular systems of the heart twitchy, irritable, and highly prone to misfiring or spasming.
Okay, that makes a lot of sense. Let's look at his second mechanism, endothelial toxicity. Steve states that inhaling combusted or vaporized plant matter damages the endothelial lining, impairing nitric oxide production and leaving arteries vulnerable to constriction. Break down the endothelium for me.
The endothelium is a delicate, ultra-thin, single-cell layer that lines the entire inner surface of all your blood vessels. You can think of it as the non-stick Teflon coating of your cardiovascular system.
Oh, Teflon coating. I like that.
Yeah, its job is to keep the blood flowing smoothly without clotting. But crucially, the endothelium is an active organ. It constantly produces a gas called nitric oxide.
Nitric oxide. I know bodybuilders take supplements for that to get a pump at the gym.
Yes, because nitric oxide is the body's primary vasodilator. It is the chemical messenger that tells the smooth muscle in the artery walls to relax and whiten.
Okay.
Now, when you inhale smoke or vapor, whether it's from cannabis, tobacco, or anything else, you are introducing intense heat and thousands of chemical toxins directly to that delicate Teflon coating. The endothelium becomes burned, irritated, and completely dysfunctional.
So the factory that produces the relaxing gas basically gets shut down?
Precisely. Nitric oxide production plummets. Without that constant relaxing signal, the artery loses its natural elasticity. It becomes stiff, reactive, and primed to violently constrict.
Wow. Okay, so his third mechanism targets systemic cannabinoid load. He points out that by completely eliminating his oral consumption, the edibles and oil's active metabolites are no longer interacting with CB1 receptors on the vascular smooth muscle.
This is a vital distinction Steve makes. The danger isn't just the smoke, it is the pharmacology of the THC molecule itself. THC and its breakdown products, the metabolites, actively seek out and bind to cannabinoid receptor type 1 or CB1 receptors.
And where are those receptors?
We now know that these CB1 receptors are densely populated directly on the smooth muscle cells of the coronary arteries.
Wait, really? So the drug is literally latching onto the muscle that controls the blood flow to the heart?
Yes. And when those CB1 receptors are activated by THC, it can send a direct chemical signal commanding those muscle cells to contract. By stopping all forms of consumption, Steve is effectively removing the chemical key that was constantly turning the lock, forcing his arteries to spasm.
And finally, his fourth mechanism, sleep deprivation. Steve identifies that his chronic lack of sleep elevated his systemic vascular resistance, impaired his vagal tone, and created a pro-inflammatory primer for spasms. What does lack of sleep have to do with your blood vessels?
It has everything to do with them. We talked about the parasympathetic nervous system, the rest and digest branch. Sleep is the primary time when this system takes over to heal and repair the body.
Makes sense.
A key component of this is vagal tone, the activity of the vagus nerve, which essentially acts as a calming brake pedal on the heart rate and blood pressure.
So if you don't sleep, you never press the brake pedal.
Exactly. When you are severely sleep-deprived for long periods, that vagal brake is completely removed. Your sympathetic nervous system stays locked in that adrenaline-fueled overdrive 24/7. Your systemic vascular resistance stays high, meaning all your blood vessels are constantly clenched tight.
Just constantly stressed.
And even worse, severe sleep deprivation triggers a massive release of inflammatory markers throughout the entire body.
So putting it all together, Steve's hypothesis is basically this. He had a chronically sleep-deprived, highly inflamed cardiovascular system, tightly clenched and lacking the brake pedal.
Right.
He introduces a heavy, continuous load of THC, which actively binds to receptors telling the arteries to squeeze, while simultaneously burning away the protective Teflon lining and shutting off the nitric oxide needed to relax them.
It is the absolute perfect, lethal storm for a catastrophic vasospasm. The artery had no choice but to snap shut.
I am not going to lie, I find this incredibly convincing, but I'm not a doctor. Steve knows his doctors are going to be skeptical of a patient lecturing them. So to force them to take this seriously, he doesn't just link to a few blog posts on the internet. He brings out the heavy artillery.
Oh, he does.
He explicitly cites the very authorities his own doctors answer to.
This is the most brilliant part of his advocacy brief. He uses the medical establishment's own peer-reviewed literature to essentially box them in.
He cites the European Society of Cardiology, the ESC, pointing out that their official briefs now isolate cannabis as a direct driver of acute coronary vasospasms via that exact CB1 receptor stimulation we just talked about.
Right, the top cardiology body in Europe.
He cites the British Heart Foundation, the BHF, highlighting their explicit warnings that smoking cannabis elevates the risk of an acute myocardial infarction in the immediate hours following exposure.
He is speaking their language, using their Bibles. He also brings in a massive meta-analysis from the highly respected journal Heart, which pooled global data to confirm that cannabis exposure significantly increases the relative risk of acute coronary syndromes.
And he didn't stop there.
Nope. He drops case reports from the European Heart Journal explicitly listing cannabis as a primary trigger for Prinzmetal's angina, noting it can cause over 90% severe constriction, even in arteries with absolutely zero underlying plaque.
He is basically saying, don't argue with me, argue with the European Heart Journal. And having laid all this out, he drops his ultimatum for this July 9th appointment. He demands collaborative medication management based on objective biomarker tracking. He doesn't just want to blindly guess. He specifically wants them to track his high-sensitivity C-reactive protein, or hsCRP, alongside his fasting lipids to safely taper off the 80 milligram statin as his inflammation subsides.
I want to emphasize how incredibly smart this is. He isn't acting like an anti-medicine zealot, just screaming, take me off all these drugs.
Right, he's not anti-science.
Not at all. He is saying, let's use actual data to justify the prescription.
Yeah.
HSCRP is a highly sensitive, objective blood marker for systemic inflammation. It tells you exactly how angry and inflamed the cardiovascular system is at that given moment.
So his theory is correct that this heart attack was an acute inflammatory spasm triggered entirely by a substance he has now 100% eliminated what should happen to that HSCRP number.
If he remains abstinent and fixes his sleep, his HSCRP should plummet over the coming weeks and months. If they track it and it stays low and his basic lipid panel is normal, the entire medical justification for keeping him on a lifelong maximum dose statin simply evaporates.
Because there is no progressive inflammatory plaque disease to treat.
Exactly.
He concludes his brief with a direct statement to his team. He writes, "I am fully committed to my recovery, have removed the clear root causes. Let's look at the science of vasospasms together, track my real markers, and build a recovery plan based on objective data." Honestly, if I'm a doctor reading that, I have to respect it.
It is the absolute gold standard of what informed, patient-centered care should look like. True medicine requires treating the specific pathophysiology standing right in front of you, not just applying a statistical blanket. Steve is forcing the medical system to look at him, his specific biological event, rather than a demographic algorithm.
But here's the thing. While Steve is fighting for his own individual care, he recognizes a terrifying reality. His case is not an isolated anomaly.
No, it's not.
He knows there are thousands of people out there experiencing the exact same thing, but they don't have the medical literacy to fight back, or worse, they just don't survive to tell the tale.
Right.
The prevailing cultural narrative right now is that heart attacks are a disease of the elderly, or people with terrible diets and completely sedentary lifestyles. But Steve is pointing to a massive demographic shift. Young, incredibly healthy people are suddenly having massive heart attacks.
And this is where we have to pivot to the clinical data that proves Steve's point on a population level. We turn to a sobering clinical case series published by Dr. Sharma and his colleagues out of the SUNY Downstate Medical Center in Brooklyn, New York.
Right, the SUNY study.
This paper is a crystal clear window into the crisis currently unfolding in emergency rooms across the country.
Let's really dig into this SUNY Downstate data. The researchers looked at 10 consecutive cases of STEMAs, again, major ST elevation widowmaker heart attacks that were definitively chemically associated with marijuana use, confirmed by positive toxicology screens in the hospital. The first statistic that just jumps off the page is the age. The mean average age of these patients was just 40.1 years old.
Let that number sink in. 40.1. In the cardiology world, 40 is considered remarkably young for a STEMI. It is an age where progressive plaque rupture is incredibly rare.
And it gets worse.
Yeah.
The age range in the study was 26 to 59, 26 years old.
It's horrifying.
Imagine being 26 and suffering a massive life-threatening heart attack. And if we look at the demographics, these were largely minority populations. Out of the 10 patients, 8 were black, 2 were Hispanic, and 1 was white. Wait, the math there. Sorry, 8 black, 2 Hispanic, yes.
The authors of the study specifically note this intersection. The disparity in cardiovascular outcomes for minority populations is a well-documented systemic crisis in healthcare. But this data suggests a deeply troubling new layer.
What's the new layer?
It points to specific cultural usage trends and the targeted commercialization of high-potency cannabis in these communities, acting as an overlooked, accelerating factor in these severe cardiac events.
Wow. But the statistic that truly stopped me in my tracks was the complete lack of traditional risk factors. I want to be really clear about this for anyone listening. 30% of these patients, 3 out of the 10, had absolutely zero cardiovascular disease risk factors when they were admitted to the ER.
Nothing.
No diabetes, no high blood pressure, no obesity, no high cholesterol.
Doctors use standardized tools, like the ASCVD risk estimator and the Framingham risk score, to calculate a patient's probability of having a heart attack over the next 10 years. These calculators look at age, cholesterol, blood pressure, smoking history, and diabetes.
And what did the calculators say about these patients?
The patients in this study had ASCVD and Framingham risk scores that placed them firmly in the low to moderate risk categories. Furthermore, none of them had a family history of early coronary artery disease.
So, by every single standard medical metric, by every algorithm the hospital uses, these were healthy individuals. If they had walked into their primary care doctor for a routine checkup the week prior, they would have been given a completely clean bill of health and told to just keep doing what they were doing.
Precisely.
Yeah.
Which brings us to the angiographic reality. When these young, healthy patients were rushed into the cath lab mid-heart attack, What did the surgeons find?
Well, just like Steve, despite having massive stemmas, the angiograms found absolutely no evidence of underlying atherosclerotic coronary artery disease. The progressive cholesterol-choked arteries you'd expect to see in a heart attack patient simply were not there.
However, they did find blockages,
Hmm.
but they were of a completely different nature. While Steve suffered a severe vasospasm, this SUNY downstate study highlights the other deadly manifestation of cannabis cardiovascular toxicity.
Right.
80% of these young patients had acute thrombus formation in their coronary system, overwhelmingly in the left anterior descending artery, the LAD.
Okay, let me make sure I have this terminology right. A thrombus is a blood clot, correct?
Yes, an acute thrombus is a sudden, massive blood clot.
So let me get this straight. Their arteries were completely clean, no plaque, no long-term buildup. But a massive blood clot just spontaneously materialized out of nowhere, lodged in the main artery, and choked off the heart.
That is exactly what the angiograms showed. And this phenomenon introduces an incredibly dangerous, almost counterintuitive paradox regarding cardiovascular health.
Okay, stop right there. I want to push back on this, or at least get you to explain it, because I am really struggling to understand the mechanics here.
Sure, it's confusing at first.
We spend our entire lives being told that clean, healthy arteries are the ultimate goal. Plaque is bad, clean is good. But you are suggesting that because these young patients' arteries were too clean, they actually suffered significantly worse damage when the spasm or the clot hit. How does being healthy make a heart attack deadlier?
It is a tragic physiological reality, and it all comes down to a concept called collateral circulation. I want you to imagine an older patient who spends decades eating poorly and smoking. Over 20 or 30 years, atherosclerotic plaque slowly builds up in their main coronary artery.
A slow-motion traffic jam.
Exactly, a slow-motion traffic jam. The artery slowly narrows. Because this process takes decades, the heart muscle downstream is essentially being slowly, chronically starved of oxygen. But the human body is an incredibly adaptable machine.
So it adjusts.
It senses this slow starvation. To compensate, the heart begins to grow the tiny, brand-new microscopic blood vessels that bridge across the narrowing artery. It literally builds its own internal detour routes to bypass the blockage. This network of new vessels is called collateral circulation.
Oh, wow. So like side streets naturally forming around the blocked highway.
Exactly. So in that older patient, when the diseased plaque finally ruptures and totally blocks the main highway, causing a heart attack, the situation is dire, but some blood can still trickle through those newly built side streets.
It's enough to keep things somewhat alive.
Right. It isn't enough to run a marathon, but it is enough to keep some of the heart tissue alive. It buys the heart muscle time. It physically limits the extent of the permanent damage.
Okay, I understand that. But what about the young people in the downstate study? Or Steve?
Those young patients, and patients like Steve, did not have a 20-year slow-motion traffic jam. Their highways were wide open, smooth, and perfectly clear. Because there was never any slow starvation, their hearts never received a signal to build those side streets. They had absolutely zero collateral circulation.
So when the massive dose of THC suddenly triggers a violent spasm that clamps the artery shut or causes a massive blood clot to instantly form.
Main highway is instantly shut down, and there are absolutely no detours. None. The ischemia, the total lack of oxygen, is immediate, absolute, and catastrophic. The heart cells begin dying in massive numbers almost instantly.
That is absolutely terrifying. The very thing that made them quote-unquote healthy made the acute event unsurvivable for the tissue. Does the data back up how bad the damage was?
The data from the SUY study is definitive. We talked about Steve's troponin I level being 529. The peak troponin levels in these young downstate patients averaged 93.5 nanograms per milliliter.
And normal is 0.03.
Exactly. Remember, anything over that is abnormal. And we can also look at their left ventricular ejection fractions.
Ejection fraction, that's a measure of how efficiently the heart is pumping out blood with each beat, right?
Correct. A normal, healthy ejection fraction is usually between 55% and 70%. Following these cannabis-induced stemmas, these young patients saw their ejection fractions acutely depressed, plummeting to an average of 43.1%.
Which means?
Their hearts sustained massive, permanent structural damage. They went from perfectly healthy to living with profound heart failure in a matter of hours.
It completely shatters the entire framework of how we assess heart attack risk. If you rely on a Framingham score, you are totally blind to this.
Standard risk calculators completely fail to predict this specific type of cannabis-induced vascular catastrophe. because they are designed to measure the slow, progressive buildup of lifestyle disease. What we are looking at here is a sudden, violent chemical event. It is a toxicity issue, not a lifestyle issue.
Okay, we know who is getting hurt, young, healthy people with clean arteries. We know what is happening to them, sudden spasms and massive spontaneous clots without underlying plaque. But to truly understand Steve's mission of informed consent, we really have to look under the hood.
Yes, the pharmacology.
We need to understand the pharmacology. We need to know exactly how the THC molecule triggers this on a cellular level. We need to validate Steve's claim of autonomic overdrive.
To understand how cannabis attacks the vascular system, you have to look at the massive supply and demand mismatch it creates in the body. It is a dual threat that hits the heart from both sides simultaneously.
Let's break that dual threat down. Let's start with the demand side. We kind of touched on this with Steve's hypothesis.
Right. When you consume THC, as we discussed, it triggers the sympathetic nervous system. The catecholamines flood the system. Heart rate spikes, blood pressure rises. The physical workload of the heart muscle skyrockets.
It's working overtime.
Because it is working so much harder, the heart's biological demand for oxygen spikes dramatically. It is screaming for more fuel.
So the engine is suddenly redlining. But what happens on the supply side?
At the exact same moment the heart is demanding maximum oxygen, the cannabis exposure actively strangles the supply. First, if the cannabis is inhaled via combustion, smoking a joint or a bong, you are inhaling significant amounts of carbon monoxide.
The exact same stuff that comes out of a car exhaust.
Exactly. And carbon monoxide has a much higher affinity for your red blood cells than oxygen does. It binds tightly to the hemoglobin in your blood, creating a compound called carboxyhemoglobin. This physically crowds out the oxygen, drastically reducing the blood's carrying capacity.
So the blood reaching the heart is essentially empty of the fuel it desperately needs.
And
But wait, people will say, I only vape, or I use a dry herb vaporizer. So there's no carbon monoxide.
that eliminates the carbon monoxide, sure, but it doesn't solve the second, far more critical problem. The THC molecule itself is a potent vasoconstrictor. Regardless of how it enters the body, THC interacts with the vascular system to make the arteries physically narrow and tighten.
Wow.
So you have a heart muscle redlining and begging for fuel, and the delivery pipes are actively shrinking and delivering oxygen-depleted blood. The heart is basically suffocating while being forced to run a sprint.
High demand, incredibly low supply. But I need to stop you here and play devil's advocate because I hear this counter-argument constantly.
Yes, here.
People constantly claim that cannabis is a vasodilator. They say it lowers blood pressure and relaxes blood vessels. People always point to the fact that it makes your eyes red as proof that the blood vessels are dilating. I mean, how can it be a vasoconstrictor if it makes your eyes red?
It is a persistent and dangerous half-truth. Cannabis does cause acute vasodilation in very specific superficial capillary beds, like the sclera of the eye, which is why they get red. It can also cause a very brief, transient drop in blood pressure immediately upon consumption. But the human cardiovascular system does not respond uniformly to drugs. The major arterial vessels, specifically the coronary arteries and the systemic peripheral arteries, react entirely differently.
How so?
Chronic THC exposure actually leads to increased peripheral vascular resistance. Over time, the systemic blood vessels tighten up and become hyperreactive. This is partially because THC actively antagonizes or blocks the body's own natural internal relaxing endocannabinoid, a molecule called anandamide.
So it blocks the body's natural chill pill?
THC essentially breaks the body's natural ability to relax its own arteries. The net result of chronic use is a tight, constricted, highly irritable vascular system primed for a spasm.
Okay, that explains the spasm perfectly. But what about the clots? The SUNY downstate study showed 80% of those young patients had a massive blood clot materialize in a clean artery. How does a plant trigger a blood clot?
This is where the pharmacology gets highly specific and undeniably dangerous. Cannabinoids have been shown in laboratory settings to induce the production of a massive amount of arachidonic acid in human platelets.
Okay, ELI-5, tell me again. Arachidonic acid, what is that and what are platelets?
Platelets are the tiny disc-shaped cells circulating in your blood, whose sole job is to stick together and form scabs or clots to stop bleeding. Arachidonic acid is a fatty acid found in cell membranes. Think of it as raw, unprocessed industrial material. On its own, it doesn't do much.
But THC changes that.
Yes. THC acts as a potent rogue catalyst. Inside the platelets, there are enzymes called KEOX1 and KEOX2. You might actually recognize the term COX inhibitors. That is exactly how over-the-counter painkillers like ibuprofen work. They inhibit these enzymes to stop inflammation.
Right, I take Advil to block COX enzymes and reduce swelling.
Well, THC does the exact opposite of Advil. THC forcefully potentiates these COX-1 and TOX2 enzymes. It shifts them into overdrive. Let's use an analogy. Imagine the platelet is a chemical factory. THC kicks down the door, takes over as the rogue manager, takes all that raw arachidonic acid material, and forces the factory to rapidly pump out highly dangerous, highly flammable end products. Specifically, it converts it into thromboxane A2 and various prostaglandins.
And I'm guessing thromboxane A2 is bad news for the heart.
Extremely bad news. Thromboxane A2 and prostaglandins are highly potent pro-inflammatory molecules. When they are dumped into the bloodstream, they cause direct chemical injury to the delicate endothelial lining we discussed earlier. They cause profound immediate vasoconstriction. And most importantly, they cause rampant platelet activation.
What does platelet activation actually look like?
The THC-induced inflammation leads to the production of another molecule called 2-AG, or 2-arachidonyl-glycerol. This molecule hits the platelets and causes them to undergo a physical conformational change.
Like they change shape.
They literally change shape, sprouting spiky tentacles that make them incredibly sticky. They begin secreting ATP, which acts as a chemical distress signal, calling every other platelet in the area to come stick to them. It triggers a massive cascading avalanche of platelet aggregation. A massive blood clot forms out of thin air, blocking the artery.
That is a terrifying chemical cascade, just tentacles grabbing onto each other. But wait, there is a massive connection here, back to Steve's discharge papers, because the medical literature highlights that certain drugs can actually stop this specific THC-induced clotting cascade, right?
Yes, this is a crucial point. The pharmacological research showed that when subjects were pre-treated with aspirin and Plavix, which are common antiplatelet medications, it successfully retarded and blocked this specific THC-induced aggregation.
So when we look back at Steve's discharge sheet, he was put on aspirin and ticagrelor, which is the modern, more potent equivalent to Plavix. He is on dual antiplatelet therapy.
That is correct, and this perfectly validates Steve's nuanced pushback against his doctors.
How so?
While Steve is absolutely scientifically correct to challenge the 80-milligram statin because the statin does absolutely nothing to treat an acute spasm or stop a THC-induced platelet cascade, the dual antiplatelet therapy he is on is actually the scientifically backed correct protocol.
Oh, I see.
Those blood thinners are the exact mechanism needed to prevent another catastrophic clot from forming while his burned endothelial lining tries to heal.
That is such a vital distinction for anyone trying to advocate for themselves. He isn't just rejecting all Western medicine. He needs to religiously keep taking the blood thinners, but he is totally right to fight the algorithmic statin.
Exactly. It is about applying the right pharmacology to the right pathophysiology.
Okay, we really need to shift gears here because while Steve's coronary spasm and the downstate clots are terrifying, the medical literature shows that cannabis toxicity can trigger even more bizarre and deadly cardiac presentations in young people.
It's not just stimulus.
Right. Let's look at two specific harrowing case studies we have in our source pile, both incidentally involving 29-year-old men.
Let's start with a case reported by Rees and Abu in Gavin Publishers. This case is haunting because it mirrors Steve's own hypothesis about himself almost perfectly, but with a much darker outcome.
Let's call this case 1, the gamer's cardiac arrest. So we have a 29-year-old male. He has a known history of epilepsy, which is currently being treated with the standard medication, levetiracetam. His parents find him in his room, drowsy, confused, and unresponsive.
And naturally, the initial assumption by the paramedics is that he just suffered a severe epileptic seizure.
But as the medical team digs into the history, the real story unfolds.
Once they were able to communicate, he admitted to enduring severe sleep deprivation due to prolonged consecutive nights of intense video gaming. And to either cope with the fatigue or just accompany the gaming, he had heavily intensified his cannabis use over the preceding days.
Severe sleep deprivation combined with a massive influx of heavy THC. That is the exact autonomic pro-inflammatory combo that Steve identified in his own brief. And what was the result for this 29-year-old?
During the ambulance transport to the hospital, his condition rapidly deteriorated. He developed oppressive, crushing chest pain and began violently vomiting.
Awful.
Upon admission to the emergency department, they hooked him up to an ECG, which immediately showed massive ST segment elevations, ischemia. And then, just minutes after arriving in the ER, his heart rhythm collapsed entirely. He went into full ventricular fibrillation.
Ventricular fibrillation, or VFib. That means cardiac arrest, right? Explain what the heart is actually doing during VFib.
In VFib, the electrical signals in the lower chambers of the heart become completely chaotic and disorganized. Instead of a strong, coordinated squeeze to pump blood out to the body, the heart muscle just violently quivers like a bag of worms.
So it's not pumping anything.
It pumps absolutely zero blood. The patient loses consciousness immediately. They're clinically dead.
So he basically dies right there in the ER.
The medical team had to act instantly. They initiated CPR and had to use a defibrillator to deliver a massive 200-joule electrical shock directly to his chest to completely reset the electrical system and force his heart to restart. They saved his life by seconds.
A 29-year-old gamer requires a 200-joule shock to the chest. Unbelievable. And when they finally stabilized him and got him to the cath lab to see what massive plaque ruptured to cause this,
the angiogram revealed a mere 30% mild lesion in the left anterior descending artery, a completely minor, non-obstructive plaque that was not causing the heart attack.
so what actually caused the VFib?
While the catheter was in, the surgeons administered intracoronary nitrates, a potent medication that forces the smooth muscle of the artery to forcefully relax and dilate. Immediately, the 30% lesion visually improved on the screen. The artery opened up.
A spasm.
It was a classic, undeniable presentation of Prinzmetal's angina. He suffered a massive, lethal coronary vasospasm triggered by the exact mechanism of sleep deprivation and THC autonomic overdrive we've been discussing. The spasm was so severe it literally short-circuited his heart.
It's just staggering. Okay, let's look at the second 29-year-old. This one is reported by Uda and colleagues in the journal Curious, the myocarditis mimic.
This patient presented to the emergency department with a very similar, terrifying set of symptoms. Severe retrosternal chest pain radiating to his arm, intense nausea, and profound diaphoresis, which means he was sweating profusely, a classic sign of cardiogenic shock.
And he had absolutely zero past medical history, right? He was perfectly healthy, but he admitted to the doctors that he had smoked marijuana just 5 hours prior to the onset of his crushing chest pain. And his blood work. I mean, we talked about Steve's troponin being dangerously high at 529. Tell me what this kid's troponin was.
This 29-year-old's troponin I levels peaked at an absolutely staggering 3,350 picograms per milliliter.
Over 3,000.
That level of troponin indicates massive, widespread, catastrophic destruction of the heart muscle tissue. It looked, on paper and on the initial ECG readings, exactly like a massive fatal heart attack caused by a blocked artery.
But they didn't find a blocked artery. They did a cardiac MRI, a highly detailed scan of the heart tissue itself, and they found something completely different from a spasm or a clot.
The MRI revealed subepicardial enhancement in the septum, the inferior wall, and the inferolateral wall of the heart.
Stop, translate that for me. Subepicardial enhancement. What am I looking at on the MRI screen?
Imagine looking at a cross-section of the heart wall. The epicardium is the outermost layer of the heart muscle. On the MRI, the contrast dye caused this outer layer to literally glow bright white. It showed diffuse myocardial edema, meaning the heart tissue itself was massively swollen and waterlogged with fluid.
So it wasn't a blockage at all?
No. This was not an ischemic event caused by a blocked artery starving the heart of oxygen. This was cannabis-induced myocarditis.
Myocarditis, meaning severe inflammation of the actual heart muscle tissue itself.
The heart muscle was literally swelling up and actively attacking itself.
How on earth does smoking a plant cause your heart to attack itself?
This brings us right back to Steve's brilliant request to track his high-sensitivity C-reactive protein, his hsCRP. We know from immunological studies that cannabis actively promotes the rapid release of CRP and highly destructive inflammatory cytokines, specifically molecules called IL-12 and TNF-alpha.
Okay, alphabet soup. What do they do?
It triggers this cascade via a very specific receptor in the body called the GPR55 receptor. When THC binds to this receptor, the immune system goes into a state of hyperdrive and mistakenly begins attacking the healthy myocardium, the heart muscle.
So it triggers an autoimmune response.
Effectively, yes. And we know exactly how dangerous this is. The Jupiter trial, one of the most massive and influential cardiological studies ever conducted, definitively proved that systematically lowering CRP reduces fatal myocardial infarctions.
Inflammation is the enemy.
Inflammation is the absolute enemy of the cardiovascular system, and cannabis is proving to be a potent, unpredictable inflammatory trigger.
But I have to bring up a huge caveat here. There's a hidden danger frequently mentioned in the literature that we must discuss, the contaminants. Are we absolutely sure it's the pure THC molecule causing this severe myocarditis, or is it what the THC is grown in?
It is a critical and completely unresolved question in the field. The reality of both the commercial and black market cannabis supply is that it is fraught with severe contamination issues. We are not just talking about the plant. We are talking about high levels of fungi, bacteria, heavy metals absorbed from the soil, and massive unregulated amounts of agricultural pesticides.
Right. Think about it like this. You can eat an organic apple, or you can eat an apple that has been heavily sprayed with a dozen toxic chemical pesticides. If you eat the sprayed apple, it's bad, but at least it goes to your stomach. And your liver, the body's massive chemical filtration plant, gets a chance to break those toxins down before they hit your bloodstream.
The first pass metabolism.
Exactly. But when you smoke or vape contaminated cannabis, you bypass the liver entirely. Those vaporized pesticides and heavy metals go deep into the lungs, cross directly into the bloodstream, and are pumped straight into the heart muscle in a matter of seconds. Could these agricultural chemicals be the actual trigger causing the heart to swell and glow on an MRI?
It is highly probable that agricultural contaminants play a significant synergistic role. They might act as the primary tractor for the immune response, or they might act as a toxic accelerant to the inherent THC-induced inflammation.
So it's a double whammy.
But frankly, from a patient outcome perspective, regardless of whether it is the pure THC molecule or the vaporized pesticides, the end result for the consumer is exactly the same. Acute, life-threatening myocardial inflammation.
Which brings us to the final and perhaps most irrefutable piece of evidence in this entire deep dive. Because look, if the cardiology data, the downstate angiograms, the 3,000 level troponin scores, and the glowing cardiac MRIs aren't enough to shatter this cannabis is a harmless, natural alternative dogma.
We just have to look at how surgeons and anesthesiologists view patients who use cannabis.
And I can tell you they view them with extreme, uncompromising caution. We have the recent highly detailed perioperative guidelines published by Dr. Limer and Dr. Todioka on behalf of the American Society of Regional Anesthesia and Pain Medicine, the ASRA. Let's start with what I call the pain management paradox. The ASRA guidelines state that over 80% of patients firmly believe that cannabis will provide effective postoperative pain relief. People go into surgery thinking, I don't want to take addictive opioids. I'll just eat some THC edibles after my knee replacement, and it will manage the pain perfectly.
It's a massive misconception.
Yeah.
And the clinical data shows the exact opposite reality. Regular chronic cannabis use actually worsens pain outcomes and makes post-operative pain management significantly more difficult for the medical team.
Wait, how does it worsen it? Doesn't it numb you out?
No. Large-scale studies involving major orthopedic surgeries, like hip and knee arthroplasties, show that chronic cannabis users actually require significantly higher doses of powerful opioid medications in the 36 hours immediately following surgery just to achieve baseline comfort.
They need more opioids.
Much more. Furthermore, these patients consistently report much worse subjective pain scores and demonstrate greater functional impairment even months into their recovery.
So, using cannabis regularly actually lowers your biological pain tolerance and makes you more sensitive to the scalpel. That is wild. But the danger anesthesiologists are worried about goes way beyond just post-op pain management, right?
Pain is secondary. Their primary concern is keeping you alive on the table. Anesthesiologists note that THC acts as a potent central nervous system depressant. It interacts synergistically and unpredictably with standard anesthetic medications. It deeply depresses consciousness and severely delays a patient's emergence from anesthesia.
So they can't wake up.
Or they can't go under smoothly. For example, a chronic cannabis user often requires a significantly higher dose of propofol, the primary induction agent used to knock you out, just to get their gag reflex suppressed enough to safely insert a breathing tube. Their entire nervous system is chemically altered and resistant.
Okay, that's the anesthesia part. But what about the actual surgical risks? How does being a regular cannabis user affect your raw chances of surviving the physical trauma of the surgery itself?
The ASRA guidelines look at data from the Nationwide Inpatient Sample, the NIS. This is a massive database that looks at millions upon millions of hospital records. The data is stark and undeniable. Active chronic cannabis users have twice the odds, a 100% increased relative risk of suffering a postoperative myocardial infarction compared to non-users.
Twice the risk of having a heart attack while you were recovering in the hospital bed.
Yes, they also have a significantly higher risk of experiencing cerebrovascular events during or after the procedure.
Strokes.
Yes, twice the risk of heart attacks and a higher risk of strokes. And we absolutely cannot ignore the respiratory impact for those who actually smoke it. Smoking cannabis exposes the delicate lung tissue to incredibly toxic byproducts of combustion, specifically acetaldehyde, nitrogen oxides, and hydrogen cyanide.
Let me stop you. Hydrogen cyanide, as in the literal poison.
Yes, it is a known byproduct of combusting plant matter at high temperatures. The guidelines explicitly note that this constant exposure leads to severely reduced lung function. Specifically, it lowers the FEV1-FVC ratio.
Explain that FEV1-FVC ratio for me.
It is a spirometry test. It measures how much air you can forcefully exhale in 1 second compared to the total volume of your lungs. A lowered ratio is the clinical hallmark of obstructive lung disease. It means the airways are inflamed, scarred, and narrowed.
So like COPD.
Yes. For the anesthesiologist, this means the patient has chronic bronchitis, heavily reactive airways, and a massively increased risk of postoperative respiratory complications. They're at high risk for developing pneumonia or suffering respiratory failure because they simply cannot be safely weaned off the mechanical ventilator after surgery.
So looking at all of this, the unpredictable anesthesia reactions, the doubled heart attack risk, the stroke risk, the poisoned reactive lungs, what do the ASRA guidelines actually mandate a doctor to do when a cannabis user needs surgery?
They issue a formal Grade C recommendation that strictly mandates delaying any non-emergent elective surgery for a minimum of 2 hours after a patient has smoked cannabis.
Why specifically a 2-hour window?
Because the anesthesiologists are directly referencing that exact Middleman study we discussed earlier. They know the pharmacological data. They know that in that specific 2-hour window following consumption, the patient's risk of suffering a massive fatal perioperative myocardial infarction is increased 5-fold due to the catecholamine surge and the receptor activation. They simply will not put you on the operating table. The risk of you dying under their hands is too great.
You know, that is the ultimate undeniable proof of Steve's whole mission, isn't it? Anesthesiologists are the ultimate pragmatists. They do not have the luxury of engaging in cultural confirmation bias.
Yeah.
They don't care about political correctness. They don't care about the legalization debates on the news, and they certainly don't care about the cannabis industry's marketing campaigns.
They just care about the monitor.
Exactly. Their only job, their only metric for success is the immediate, raw physiological reality of keeping a human being alive on a table while their body is being subjected to massive surgical trauma. And the fact that their strict, uncompromising protocols treat cannabis use as a massive red flag risk factor is screaming proof of its systemic toxic impact.
I completely agree. When the highly specialized doctors responsible for managing your literal life support systems view a culturally accepted substance as a high-level perioperative danger, the public desperately needs to pay attention.
This brings us to the end of this incredibly heavy deep dive. I want to synthesize everything we've unpacked today and bring the narrative squarely back to where we started, with Steve Collins fighting for his life and his care.
The ultimate takeaway here is that Steve is not crazy for challenging his cardiology rehabilitation team. His clinical advocacy brief is not just the angry ranting of a patient who Googled his symptoms. It is a scientifically rigorous, data-backed defense of his own unique biology.
The data we've looked at today is simply overwhelming. We started with the SUNY Downstate case series, showing healthy 40-year-olds with perfectly clean arteries spontaneously forming massive, choking blood clots.
Right.
We looked at the European case reports of 29-year-olds going into sudden cardiac arrest from violent Prinzmetal spasms after just gaming and smoking. We saw MRIs of heart swelling and attacking themselves. And we ended with the American Society of Regional Anesthesia treating cannabis users as high-risk, fragile surgical patients.
The peer-reviewed evidence proves, beyond a shadow of a doubt, the cannabis is a highly potent, incredibly complex drug capable of triggering massive vascular inflammation, rampant platelet aggregation, and lethal coronary spasms, especially when you combine it with environmental stressors like Steve's severe sleep deprivation.
Steve's core driving mission in sharing his medical trauma is about informed consent. The global cannabis industry is booming, and there is immense billions of dollars revenue at stake in maintaining the harmless narrative. But consumers, and just as importantly, primary care doctors and cardiologists on the front lines, must wake up to the reality of THC-induced acute coronary syndromes, generic algorithmic lipid dogma blindly prescribing an 80-milligram maximum dose statin to a patient who just suffered a chemically induced vasospasm is a profound failure of personalized medicine.
It is treating the plumbing, when the house just had a massive electrical and chemical fire.
Mm.
It ignores the root cause entirely.
Precisely. We have to evolve beyond the algorithms. We need to start tracking objective biomarkers of actual inflammation like Steve demanded with his HSCRP levels. And we need to treat the specific underlying pathophysiology standing right there in the examination room.
That's the only way forward.
As we wrap this up, I want to leave you, the listener, with a final thought to mull over. Something that builds on everything Steve is fighting for today. We live in an era where we demand microscopic transparency about every single thing that goes into our bodies. We demand to know if our food is non-GMO. We want to know if our bottled water has trace minerals. We demand a multi-page pamphlet if our prescription pharmaceuticals have a 1% chance of causing a mild rash or a headache. We are culturally obsessed with biological purity and safety warnings.
Yet when it comes to a rapidly legalizing, highly potent, genetically modified psychoactive plant, we seem collectively, willfully willing to look the other way. We just accept the natural is safe marketing slogan without a second of critical thought.
Exactly. I want you to truly ask yourself this. If a major multinational pharmaceutical company released a brand new synthetic drug tomorrow, and the clinical trial data showed that it caused a 5-fold increase in massive heart attacks within an hour of use, and was sending healthy 29-year-olds into cardiac arrest and causing their hearts to swell and attack themselves, would that drug ever get approved by the FDA? Would it ever see the light of day on a pharmacy shelf?
Of course not. It would be recalled immediately, and there would be congressional hearings.
It is time we start treating cannabis with the physiological respect and the profound caution it biochemically commands. Because right now, for patients like Steve Collins, that comforting binary medical system is broken, the algorithms are failing, and they are left navigating the terrifying muddy waters of drug-induced heart failure entirely alone.